Evaluation of yolk sac tumor in a pediatric patient with F18FDG Peru time/Central Time. Guler-Silov, Nilofer Bikaxi, Fadi Body, Banu Kurtiloglu. Introduction. Malignant germ cell tumor MGCT, of which yolk sac tumor YST, is the most common subtype, accounting for only 1 to 4% of childhood malignancies. YST is thought to arise from primitive germ cells. YST can be of testicular, ovarian, or extragonadal origin. The level of alpha-fetoprotein AFP is high in most patients due to the endodermal origin of YST. Therefore, the level of AFP is considered to be an important biomarker. The outcome of patients with YST is closely related to the stage of the disease. Studies have shown that children with gonadal YST in stage may first benefit from surgical intervention. F18FDG Peru time/Central Time is a system that integrates metabolic imaging with anatomical imaging. F18FDG Peru time/Central Time is widely used in pediatric lymphoma, neuroblastoma, soft tissue sarcoma, and other malignancies. However, the use of F18FDG PET/CT in pediatric YST has mostly been reported in case reports. In this report, we evaluated the usefulness of F18FDG PET/CT in the initial staging of the disease, in the assessment of chemotherapy response, and in the restaging of the disease after chemotherapy and second surgical treatment. Case report. A 15-year-old Syrian girl patient underwent surgery for abdominal swelling and pain in her country. A right salpingo-oophorectomy was performed. A mass measuring 220 by 150 by 120 millimeters was removed. Pathology report compatible with an ovarian YST. Then the patient was admitted to our hospital for treatment. Blood tests showed AFP 426 ing/ml, reference range 0 to 40 ing/ml, beta HC 0.1 myo/ml, reference range 0 to 10 myo/ml. Abdominal and pelvic MRI, F18FDG Peru time/Central Time imaging, and USG were performed. A total of 4 F18FDG Peru time/Central Time scans of a pediatric patient were analyzed. F18FDG Peru time/Central Time images were evaluated retrospectively by 2 nuclear medicine physicians by consensus. Both were blinded to the clinical and imaging findings. F18FDG PET/CT images were interpreted as positive or negative for disease. Any non-physiological focal F18FDG uptake on PET was anatomically localized on CT. Semi-quantitative analysis was performed using the maximum standardized uptake value, SUV max. On evaluation of the first postoperative F18FDG Peru time/Central Time scan, multiple hypermetabolic lesions were observed on the left side of the pelvis on the MIP image. Cross-sectional imaging at the level of the pelvic inlet showed metastatic foci in the right rectus abdominis muscle, and a metastatic focus near the left psoas muscle were hypermetabolic. Pelvic masses anterior and posterior to the uterus and a mass in the anterior wall of the left pelvis were hypermetabolic, and pelvic fluid was observed. At the level of the pelvic floor, increased F18FDG uptake was seen in a hypodense lesion in the left rectus abdominis muscle and in inguinal lymph nodes. The cisplatin adipocyte PB chemotherapy protocol was used. The second follow-up F18FDG Peru time/Central Time scan was performed after 2 cycles of the PEB protocol. In the last F18FDG Peru time/Central Time scan, no pathological FDG uptake was observed in the pelvic region on MIP images. Cross-sectional imaging at the level of the pelvic inlet showed a calcified lesion without significant FDG uptake in the right rectus abdominis muscle. No mass was observed in the left lateral psoas muscle. At the level of the uterus, there was no significant FDG uptake in the calcified lesions of the left anterior pelvic wall, and no other lesions of the pelvis were observed. Table shows the temporal change in the number, size, and metabolic activity of the lesions after initial surgery, following response to chemotherapy, and at the end of treatment by F18FDG PET/CT imaging, and the decrease in serum AFP levels. Following MRI findings of a slight increase in the size of a calcified mass in the anterior wall of the pelvis, a decision was made at a consultative meeting to excise the mass and surgery was performed. The patient's current pathology was compatible with a mature teratoma. A decrease in AFP level is shown in Figure 4 in table. Mature teratomas are considered benign and are not included in the management protocol. The patient is currently stable and under close observation. No residual disease was found on the second post-surgery imagings. No distant metastases were observed. Discussion: YST is a rare tumor that is often included in the MGCT subgroup. Few studies in the literature have focused on YST alone. Most studies in the literature have focused on MGCT, a heterogeneous group that includes seminoma, dysgerminoma, embryocarcinoma, choriocarcinoma, polyembryoma, gonadoblastoma, and teratoma. There are few studies on the usefulness of F18FDG Peru time/central time in MGCT, and most of these have been in the adult population. There are even fewer studies on the use of F18FDG Peru time/central time in pediatric MGCT. It is important to clarify the usefulness of F18FDG Peru time/central time in pediatric YST. The value of F18FDG Peru time/central time in preoperative staging of pediatric YST or MGCT is unknown. F18FDG Peru time/central time is not routinely recommended for initial staging of MGCT in adults because of the small additional benefit of F18FDG Peru time/central time compared with CT or MRI. In our study, although F18FDG Peru time/central time provided additional metabolic information to conventional imaging, the F18FDG Peru time/central time findings did not change the stage of the disease and therefore did not change clinical management in the initial studies. However, last F18FDG Peru time/central time images contributed to the decision to refer the ametabolic pelvic anterior wall mass for surgery. Histopathological examination showed that the lesion was compatible with benign mature teratoma. Conclusion: F18FDG Peru time/central time is an imaging modality with high diagnostic accuracy in demonstrating anatomical and metabolic response to chemotherapy after surgical treatment in patients' YST. It can show tumor differentiation at follow-up and has a major impact on therapeutic management.